Good evening, ladies and gentlemen, and welcome to tonight's JCN Facebook Live. The title of tonight's event is Improving Hard-to-Heal Wounds by Managing Edema and Fibrosis. And our fantastic speakers here with me now is Julie Stanton. Good evening, Julie.
Good evening, Ed.
Are you well?
I'm well. How are you?
Very good. Very good. Thank you for your support tonight. Ladies and gentlemen, as you can see, Julie is doing tonight's presentation from home. So if we have any technology issues, please bear with us, and I promise you we'll sort them out as soon as possible. The link for your certificate of attendance will be made available towards the end of tonight's event, and this counts towards your revalidation. And all the slides you're seeing tonight are available for download on the JCN website. As Julie will agree, the more involved you are, the more comments, the better it is for the event itself. And please ask any questions whatsoever, and we'll endeavour to answer as many of them as possible towards the end of tonight's event. Before we start, a massive thank you to our partners tonight, who are Thuasne. Thuasne have partnered us not just tonight, but across the year on a variety of different educational platforms. And without your support for independent education, these events simply could not and would not happen. So a massive thank you from me and my team. So without further ado, it gives me great pleasure to introduce our speaker tonight. Over to you, Julie.
Good evening. My task tonight really is to look at, as Ed said, looking at hard-to-heal wounds by managing edema and fibrosis. I'm the Director of Nursing for Pioneer Wound Telehealth, and I've got extensive experience in tissue viability, mainly in the community, developing one of the first tissue viability community services in Birmingham quite a few years back. And one of the big things that I looked at when I worked there was that we had very little in relation to lymphedema services for patients with wounds or lower leg non-cancer related lymphedema. So about 20 years ago, I also undertook the lymphedema course. So a lot of the information that I'm giving you comes from sort of two aspects, the tissue viability aspect, but also with my other hat on as a lymphedema nurse. So let's have a look at the next slide. Okay. One of the things I want to really talk about is what do you think is your predominant leg ulcer etiology? Because we're all taught from a tissue viability aspect that the predominant leg ulcer etiology is usually venous. One of the things that I found out over the last couple of years working with Pioneer and working with different community trusts is that that really isn't the case anymore. The assumption is that it's predominantly venous. However, when we start looking at the figures that I'm going to show you in a minute, you'll start to see that the predominant etiology tends to be, especially in complex leg ulcer clinics or in the community, is lymphovenous. Ellis in 2015 states that historically lymphovenous disease has been underdiagnosed conditions due to, in part, the misdiagnosis of chronic edema. And I think lots of nurses get very confused with the terms chronic edema and lymphedema. They are one and the same. And the problem is when you start talking about two different things, nurses can get quite confused. So again, one of the things that you need to think about is what are you actually seeing? Do we need to rethink leg ulcer etiology, how we assess and how we treat to improve our outcomes? And that's one of the things that I've been doing over the last sort of 25 years, is actually looking at how we treat them and how we assess patients with leg ulcers. Now, these two graphs, basically from the next slides, look at, these are Pioneer figures on the right-hand side, which look at the different types of leg ulcers that we've seen in our clinics. And as you can see, we had 254 VLUs within the 6 leg ulcer clinics that we have. But we also had 204 patients with lymphovenous disease, whether that's sort of 2A, 2B, 2 or 2B lymphedema. We have very few sort of MAUs, very few arterials, because they tend to get referred before they come to us. The other graph that you can see there, the pie chart that you can actually see, not a graph, actually is work that I've been doing with a local community trust, looking at their leg ulcer service or their wound care clinic. And within their leg ulcer clinic, we only found 13 of the 128 patients that we had referred to us at Pioneer. Only 96 were leg ulcers. No, 113 were leg ulcers, of which 96 were lymphovenous. And when I first asked the nurses within the clinics how many patients they had with lymphedema, they basically said about 3 they thought. When we started triaging the patients, what we were seeing were these patients that had positive stemmer sign, where you can't pick up the skin from between the digits. They had swelling to the toes, to the knees. And a lot of these patients had stage 2B lymphedema due to end-stage chronic venous insufficiency. A lot of these patients had the same patterns of recurrent infections. And there were only 8 patients with what we call stage 3 lymphedema, predominantly due to obesity, on their caseload. So looking at these figures, we only found, as I say, 13 that had straightforward venous disease. However, how we look and assess and treat these patients is very much from a venous etiology. So we treat them with venous bandaging, we treat them with venous techniques. We look at exercises related to the venous system. We look at elevation related to the venous system. We don't really look at the underlying etiology of lymphatic disease as well as lymphedema. The next pictures actually show you some of the patients that we were actually referred. Now, as you can see, these patients don't have straightforward VLUs. They actually have, as I said before, swelling to the toes, swelling to the knees. They have hard fibrosed edema. They have shape distortion. They have ulceration to the foot. When you start looking at these patients, we need to start looking at them in a very different way and treating them very differently. So as a lymphedema nurse, I introduce lymphedema techniques to work alongside my tissue viability expertise. Now, lots of patients that come to clinics now, you're seeing with this type of disease, or you're seeing it in the community. Why have these patients sort of been out there, and why are they developing the lymphedema? Well, if we start looking to certain things that are contributing factors to that increase in lymphedema, you've got increased survival of heart failure patients, numerous medications associated with edema, things like the channel calcium blockers, increased incidence of obesity. We've got an aging population, less mobile. We've got increasing surgical procedures involving removal or damage to the lymph nodes. We all know about if you have a mastectomy, you need to be careful of lymphedema in the arm. However, we don't tend to sort of consider the same sorts of things for those patients that have hip replacements, knee replacements, prostatectomies, hysterectomies. We don't actually sort of link the removal of those lymph nodes as we do with a mastectomy. So those patients that have had maybe knee replacements where they've actually damaged the nodes behind the knee, the lymph nodes behind the knee, they may, when they become immobile later on down the line, they'll develop lymphatic disease. And we know that the incidence of lymphedema will increase in the up and coming decades. It's always been considered a bit of an orphan disease because it doesn't really fall into any sort of medical speciality. Consequently, few doctors and nurses are well versed in how to actually treat it. And again, until I did the course as a tissue viability nurse, I didn't really know that much about lymphedema or the lymphatic system, or how it actually impacts on wounds themselves. So if we look at lymphedema and wound development, we know that the percentage of patients with chronic edema in the community setting is between about 52 to 69%. One of the things they also found with these patients is that 73% of them also had a leg ulcer. And lymphovenous edema is the most common form of lymphedema in the Western world, yet we don't really know how to treat it particularly well. We tend to look at, as I said before, looking at treating it in a venous way. And I'll explain what I mean in a venous way in a little while. So end-stage chronic venous insufficiency leads to the development of lymphedema, especially if we have patients that have that recurrent episodes of infection. How many of your patients out there have every 6 to 8 weeks another infection on top of another infection on top of another infection? And that bacterial burden, this causes prolonged edema, and the lymphatic impairment can delay wound healing, because every time the patient has an infection, it damages the lymphatic system even further. And that's the sort of cycle that we need to break. And that's one of the things that we need to look at when we're actually assessing and treating our patients. If we look at the microcirculation, now we've always been taught that the law of Starling's law, where we always said that it was reabsorbed back into the venous end, but we now know that there is no reabsorption back into the venous end of the blood capillaries, and only what we call a diminishing fluid filtration across that capillary bed. So what we now know is that all interstitial fluid, 100% of it, is reabsorbed by the lymphatic capillaries alone. So if those lymphatic capillaries aren't working, and if they're damaged, we know that that fluid will remain. And consequently, all edemas are on what we call a lymphedema continuum and represent relative lymphatic failure or insufficiency. So in order to actually deal with that edema that's present, you need to understand how the lymphatic system works and how to make the lymphatic system work better in your patients with leg ulcers. So let's have a look at chronic lymphedema, chronic edema or lymphedema. I prefer to call it lymphedema. It just makes things easier. There are different stages of lymphedema, and a lot of the chronic edema falls into the very sort of early stages of lymphedema. So without appropriate treatment, what happens to the tissues is they become hard due to that accumulation of waste products and the failure of the lymphatic system to actually drain that excess fluid. So what happens over time is the tissues become increasingly hard, fibrosed and non-pitting, and the edema fails to reduce on elevation. So when you start to feel the leg, it feels absolutely solid all the way up. And a diagnostic test, as I said, for this is a positive semi-sign, which is when a fold of the skin cannot be picked up from the base of the second toes. By this stage, the symptoms are usually quite severe and are usually irreversible, but they can be treated. So what significance does that have when we start looking at leg ulcers and why they don't actually heal? So what is fibrosis itself? So when we start looking at normal wound healing, any sort of response to cellular damage is to produce the things like transforming growth factors and other factors which produce local inflammation, cellular activity essential for wound healing. However, when you've got fibrosis there, the structural elements of the tissue are replaced with excessive scar tissue comprised of distorted collagens. So when they are, as I said, when they're actually subjected to that persistent trauma, which is usually infection or inflammation, that normal sort of state of wound healing is actually affected, and it just goes awry. And this creates this chronic inflammatory environment where the cytokines, growth factors and signaling molecules are released, which acts to enhance the whole fibrotic process. So every time, again, as I said before, every time the patient has another infection, that actually enhances this fibrotic process. So around your wound bed, you have this fibrotic tissue, and around the leg itself, you have this hard fibrosed tissue. And what this actually does is it actually impedes the normal functioning of the organ, leading to chronic static wounds due to that continuous infection cycle, further damaging the lymphatic system. So unless you can actually break that fibrotic tissue down, you're not going to get very far with actually healing the wounds. You've all got patients where you've actually got a really good blood supply to the wound, and the patient's comorbidities are fairly well controlled, but for whatever reason that wound remains static. And one of the reasons we think the wounds are static is because they've got lots of fibrosis around it, which is not actually allowing oxygenation and nutrients to get to that wound bed. So it doesn't actually allow the wound to heal effectively or very quickly. So this protein-rich fibrosed edema that we see in lots of our patients, and you can see the pictures on the right-hand side, that fibrosis can sometimes lead to vascular problems. You've got debris, dead cells, and other byproducts of wound healing. They cause that stagnation of the wound environment, and they actually slow wound healing down. And you see it in so many of your patients within your clinics or within the community. Therefore, the simple compression that we tend to use, which basically means compression that starts from the ankle. We know we do toe to knee, but the actual compressive element starts from the actual ankle itself, which is venous bandaging. And that tends to concentrate the proteins further by removing some of the water, but the remaining proteins, which are really large, will hold on to water molecules. And that will affect the nerves, causing pain and discomfort. And a lot of your patients will actually get additional pain and discomfort, and sometimes they don't tolerate compression particularly well because of this. And they get this persistent cellulitis, this persistent infection cycles that you see in lots of your patients. And then you get that hard to heal wound that we see with, again, a lot of our patients within clinics and community. So one of the things I'd like you to start really looking at is, how do we start looking at just the assessment process itself? Now, we've all got the vascular etiology checklist, which is sort of arterial, venous. You need to start looking to add that third line, which is the lymphovenous or lymphedema. So you need to start to look for, has your patient got moderate or severe hyperkeratosis, that overproduction of skin cells? Have they got any sort of skin folds? Have they got that papillomatosis, that orange peel skin that you tend to see in patients? Have they got that lipomastoid that inverted champagne bottle leg? Have they got edema above the knees? Have they got edema to the toes or in the foot itself? Does the edema not reduce on elevation? Do you have episodes of lymphorrhea? Do you have sort of engorged lymphatics, the lymphangiomata? Have you got that hard fibrotic edema? And start to look at things like the number of inflammatory episodes or cellulitis that the patient has. If the patient has got lymphedema, the BLS, British Lymphology Society, recommend that the patient should be on prophylactic antibiotics if they've had 2 or more episodes in a year. And again, GPs are aware of these guidance, and we should be following that to help some of our hard to heal patients. So again, just by actually changing how we assess, we can start to then look at how we treat those patients. So the way that we treat our patients with this sort of edema is that we start to look at targeted compression and breaking down that fibrosis. So when we look at commencing treatment, we focus on the compression management for both the presenting ulcer. So look, we're starting to look at the tissue viability aspects of the ulcer, and for the lymphedema management. So the compression aims to, what we say, take the fluid to what we call soft spots to aid drainage. So when you're actually feeling the leg, you actually do what we call a bow tie effect. You start to sort of squeeze to see whether or not you can actually pinch the skin. And if you can't pinch the skin in a bow tie effect, then you know that that is hard fibrosed edema in the leg. And what you have to do is try and find a soft spot where that doesn't happen, where you can actually do that bow tie effect. Now, sometimes that actually is above the knee. So with those patients, you have to take the fluid above the knee to where the patient's draining to. Otherwise, what we tend to have is hard fibrosed knees, because the fluid gets to the knees, can't go any further. So you get those hard fibrotic knees. Patient can't bend the leg, the venous system doesn't work, the lymphatic system doesn't work. So the other things that we do is we use Kinesio to allow drainage, and strapping techniques to improve sub-bandage pressure, which I'll talk about in a minute. We then need to look at targeted compression areas such as the toes and knees where edema is present. Now, the simple solution with knees is literally the knee wraps. Toes, it can be the toe bandaging or toe caps. And we tend to go for multi-layer short stretch bandaging applied in a figure of 8. Again, I'll talk about that in a couple of slides' time. The other thing that we do, as I say, is break down that fibrosis. So we adapt lymphedema techniques to break down that fibrotic wound bed, to allow the oxygen and nutrients to the wound bed by either strapping, mobilizing foam pads, or Kinesio tape. And the easiest method that we find is foam pads, the actual mobilizing foam pads. I'll talk about each of these methods individually. So treating fibrosed edema, that's a patient that we've got with lots of problems. You can actually see the patient's got stage 3 lymphedema. You can actually see the engorged lymphatics, the papillomatosis, the shape distortion, the hard indurated fibrosis there. So what we do with this type of patient is we use either creative wool applications, so we use the orthopedic wool in different ways, in sausage shapes, etc. We pad out. We use Kinesio tape to actually take the Kinesio tape to a soft draining soft spot. We adapt bandage techniques. We use chevron strapping, which I'll talk about. We encourage the patient to use simple lymphatic drainage techniques. So we teach the patient very simple massage techniques to actually encourage drainage. And we use foam applications such as I said, mobilizing foam pads or custom cut foam pieces. And that will actually massage the areas. And again, I'll talk about those in a while. So let's have a look at Kinesio tape. How does Kinesio tape work? What happens with Kinesio tape is it lifts the skin to form what we call a negative pressure. The lymphatic system just sits underneath the skin. So if you just lift the skin up, the lymphatic system will start to move. And what happens is the blood and the lymph dilate and drain. And the tape increases the space in which the lymphatic fluid flows, and it works towards any lymphatic lymph nodes. So what you do is you basically find out where the patient's draining to, and you take the end of the tape to where the patient's draining to. The Kinesio tape also helps to what we call facilitate the stretch response of the angiones with movement or muscle contraction. So the way that the lymphatic angiones work is they'll actually contract, so they actually sort of move. So what we basically do with any sort of kinesio is we patch test for 24 to 48 hours, and what you do is you position the body to achieve maximum stretch. The skin should be clean and dry and free from cream, and when relaxed the tape should actually wrinkle. And as I said before, you need to take the tape to where you've actually got a draining soft spot. So you basically need to feel the skin to see where that draining soft spot actually is. And the only real contraindications to kinesio are if you've got an infection or cellulitis present, or if you've got fragile or sensitive skin or any sort of malignancy in the area. What you see here is a retromalleolar wound, which are usually a nightmare to actually heal. They can be tiny little wounds, but they seem to take months to actually heal. So how we deal with it is when you actually start to feel the skin around the retromalleolar, it's hard, it's usually quite fibrosed. So we use the kinesio tape to actually soften the area as well, and actually help the lymphatic system flow. And as you can see from this patient, just by kinesio tape application and foam applications, you can actually get the wounds to heal quite quickly. You've then got things like strapping techniques, and these are used over areas of fibrosis to add additional pressure. This technique provides specific areas of extra stiffness to facilitate that wound healing. So it's basically standard application of cohesive inelastic bandaging using the same size bandage. What we do is we apply strips of bandages of full stretch in a crisscross. So you think about the X factor, and it's a 50% overlap in a star shape over the area of fibrotic tissue or over the area of the wound. And these methods will actually alter the pressure. You also use chevron strapping that was developed from Accelerate CIC. Hopkins in 2013 looked at the sub-bandage pressure delivered with the use of elastic compression to the retromalleolar fossa area. We've already said about these ulcers tend to be quite hard to actually heal because of where they are. And the reason being is when you actually get the patient to walk, the sub-bandage pressure actually reduces dramatically to these areas. So therefore, what you need to do is increase the pressure to the area to actually keep the bandage in place. So we use the strapping techniques to actually keep the bandage in place, to keep that additional pressure close to that area. And this sort of increases the pressure to about 25 to 48 millimeters with the addition of the strapping technique. So again, things like the strapping technique, there's videos online that you can actually look at to see how this works. But this actually works really well with those retromalleolar ulcers, but also the fibrotic tissue that we're seeing in some of our wounds. The other thing that we tend to change as opposed to sort of venous is we tend to use multi-layer short stretch bandages, which give you a high working pressure and a low resting pressure. However, what we don't do is we don't actually apply it in a spiral, we apply it in a figure of 8. The manufacturer's instructions will obviously tell you that for using short stretch bandage, you put it on in a spiral. However, if you've got lymphedema present, you will always apply it in a figure of 8. And again, it's about contacting the companies to see if they'll give you some education, which all of them will, on how to use them for lymphedema rather than venous. And as I said before, venous bandaging techniques commence at the ankle. What you need to do with lymphatic disease, if they've got swelling to the toes and the foot, you need to actually start the compression from the actual toes themselves. So what we tend to do is we use an 8 centimetre short stretch from the toes to the ankle, and then we'll use a 10 centimetre from the ankle to the knee. And sometimes we'll go above the knee, or we'll put knee wraps on if there's edema above the knee. But we always apply in a figure of 8, and it's layered dependent on the ankle size, because normally with a large ankle circumference of sort of 26 to 30, what you'll do with a short stretch bandage, if it's applied in a spiral, is you'll start the second bandage from the ankle, and it goes in a clockwise or anti-clockwise way, depending on how you put the bandage on. With lymphedema bandaging, you'll actually put as many layers on as you actually need, depending on the size of the ankle, and it's basically layered. And it all again depends on the density and the fibrosis and the fibrotic tissue that's actually present. So we tend to change the number of layers and we put a figure of 8 bandage on. So again, it's about changing from a venous technique to a lymphedema technique to actually aid healing. And a lot of nurses, again, that we work with don't sort of think that it's going to work because they've been using with their short stretch bandages before, but actually applying them in a figure of 8 and changing the way that which we layer it has a really specific effect on the lymphatic system. So it actually makes it really rigid and it forces the lymphatic system to work. And I'll show you some of the results. We've got some case histories that I'll show you a little bit later on. The other technique that we tend to use is the mobilizing foams. These mobilizing foam techniques are used by lymphedema therapists to help reduce tissue fibrosis. Now, I started using these on patients with breast edema. So we'd put the actual pads into the bras, that sort of thing, to actually they massage the area and actually break down the fibrotic tissue. So we actually thought, well, let's have a look and see if we can use the same techniques in patients with fibrotic areas around their wound beds. So what they do is they help to maximise the effect of compression bandages by delivering that consistent pressure and shear forces over a greater surface area. So the pads are actually applied to mobilise the tissues and move the lymphatics to reduce the fibrosis. And they can consist of foam pads, silicone pieces, cup foam and adapted cup foams. We can also use channeled foam. And what this does is it helps to create tissue stretch and it moves the lymphatic system along the pathways. So again, it's something that you can use quite easily in practice. And it's something that we use a lot with our patients with wounds, with fibrotic wound beds. What you have to do if you're going to use this type of product is make sure the skin is resilient enough to withstand the pressure and shear force from the foam cells, because it will actually gently sort of massage the patient's skin underneath, breaking those protein-rich molecules down. There needs to be indurated edema. If the leg has little edema and the skin is fragile, then we just don't use it. We only use it for the hard indurated legs that we see. Sometimes we put a window in the pad where the ulceration is present if you think the patient may experience additional pain, already has a painful ulcer site, so we put a window in the dressing itself. We don't use them on infected wounds. And you need to understand the principles of targeted compression alongside the use of the mobilizing foam chip pads. What you really shouldn't do is use them without actually understanding how targeted compression actually helps, otherwise they won't work. But if you use them effectively with the targeted compression, they work extremely well. So the use of the mobilizing foams, how to actually use. What we tend to do is we put a cotton stockinette next to the skin, and then orthopedic wool if we require it. The pads are then placed either around the wound bed in order to cover the area of fibrosis or over the area of fibrosis on top of a primary dressing. So you can put your normal primary dressing on and you can put the mobilizing foam pad over the top. And as I said before, you can cut a window in the dressing itself, in the pad itself. And then you apply the normal bandage wraps or hosiery over the top of that. And as you can see here, we've got a patient with a really fibrotic foot where you've really got quite hard indurated edema there and fibrotic tissue there. So we're using the mobilizing foam pads to actually break down that fibrosis. When to discontinue use? Once the fibrosis has softened, trauma associated with its use, we tend to discontinue it straight away, or if there's any pain felt by the patient, or if there's any wound infection present or suspected. And the beauty about these pads is that as long as they're not soiled, you can keep using them underneath the bandages or underneath the hosiery or a wrap. This is just one of the case studies that I said I'd actually looked through. This gentleman had leukemia, had an ulcer of 6 months duration. So what we did with this gentleman, we incorporated a short stretch bandage applied in a figure of 8. We did retromalleolar strapping and a mobilizing foam pad. And as you can see, if you're looking at the two pictures, the peri-wound area softened. The wound went on to heal within 6 months, despite the patient's multiple comorbidities. And you can actually see, if you look at the surrounding sort of peri-wound area, you can actually see where the pads have had indentations. And people tend to worry about that, but that's actually sort of normal with the use of the mobilizing foam pads. But as you can see, that hard indurated peri-wound area has actually softened, allowing the wound bed to actually heal. The next patient, this patient had ulcer on the right leg. and she had a combination of strapping, mobilizing foam pads applied. The ulcer size reduced quite dramatically with softening of the peri-wound area within about a 4-week period, and she did go on to eventually heal. But as you can see, just in a small amount of time, you can actually see the area looks softer, the tissue feels softer. And the final case study was done with one of the community trusts that we're actually working with at present. And this gentleman had the ulcer for 5 years. He'd got recurrent episodes of infection, which had led to fibrosis. As I said before, stage 3 lymphedema and papillomatosis around that peri-wound area. And as you can see with that photograph, you can see the engorged lymphatics there. You can see this patient has had multiple recurrent infections, which has actually damaged the lymphatic system more and actually caused more fibrotic tissue. So what we did with this gentleman, he had wounds to both the medial and the lateral malleoli. So we put him onto quite a strict antimicrobial pathway. We curetaged the wound bed to basically prepare it. And we used multi-layer short stretch bandaging in a figure of 8. So again, we used an 8 centimetre and then a 10 centimetre. And we taught this gentleman to do some simple lymphatic drainage to take the fluid from below the knee above. And we put localized strapping to break down that fibrosis. We use Kinesio tape to improve the lymphatic flow, and we use mobilizing foam pads to break down the fibrotic tissue. Now, looking at the other leg, he healed within 133 days. Now, when you start looking at that, you can actually see that those simple techniques, those lymphatic techniques, will actually allow a very, very chronic, complex wound to heal very, very quickly just by changing the techniques that we're using. So we took him out of what we call his venous bandaging system, and we introduced the lymphatic bandaging system with the adjunct therapies like the Kinesio, the strapping and the mobilizing foam pads to break down that fibrotic tissue. And with that, he healed. He couldn't believe he healed so quickly, and neither could the nurses in the clinic. And it literally is just changing the etiology. So it's not a venous leg ulcer, it's a combination of lymphatic disease and venous disease. So we treated him very, very differently. We assessed him very, very differently. Now, to have a look at sort of the summary of this, and again, it's very difficult to sort of go through everything in any great detail in these sessions, but again, a lot of the companies will offer you training on bandaging techniques, on the use of Kinesio, on the use of the mobilizing foam pads. So again, it's about contacting those companies to give you additional training. So for me, to summarize the sort of the session is assessment. Assess the type of edema that you actually have. What is the patient presenting with? And if you do that, you can treat the wound effectively. Have you actually got lymphovenous disease? Do you have to think about very, very simple lymphatic techniques with your patients? Look for fibrosis. If fibrosedema is present, treat appropriately with adapted lymphedema techniques rather than those pure compression, venous compression techniques. So you start the compression from the foot, you look at the toes, you look at the knees. You look at introducing simple techniques to actually improve the lymphatic flow. And start looking at treatments. And again, lots of nurses will talk about, well, I'm not a lymphedema nurse, I've not had any lymphedema training. And again, these are very simple techniques that I've actually taught to a local community trust within a leg ulcer clinic, just simple lymphatic techniques that can be used in your day-to-day practice. We're not asking you to sort of look at very, very complex lymphedema, stage 3 lymphedema. We're asking you to sort of look at how you can adapt some of your processes. So we look at what we call congestive decompression therapy, which is CDP, consisting of a combination of multi-layer lymphedema bandages, which is short stretch. We're looking at wraps, the use of simple lymphatic drainage, look at the use of Kinesio taping. They're looking at the use of mobilizing foam pads, looking at the use of simple exercise techniques to improve your patient's lymphatic flow, and looking at simple sort of skincare techniques. Again, lots of things that you can learn very, very easily and introduce into your practice. And what all these sort of this CDP offers you is it helps to mobilize that accumulated edema and increases that lymphatic flow, which results in a beneficial therapeutic effect on the fibrous sclerosis that's actually there. So if you can break down that very hard indurated tissue, as I said before, what that actually does is it actually allows oxygen and nutrients to actually get to the wound bed. It reduces that recurrent infection cycle that you see in your patients. So it stops having that every 6 to 8 weeks they have another infection. You stop that, you keep the wound bed clean, you actually get the lymphatic system to do its job effectively. And this actually then assists in the healing process in those hard to heal wounds that we see on a regular basis. So just by changing, just using simple techniques and learning sort of different ways to treat leg ulcers, you can actually achieve much better healing rates. And our healing rates within our combined services, where we have lymphedema nurses and tissue viability nurses, they do a hybrid training. So the tissue viability nurses also do lymphedema. And by actually doing that, we can, our healing rates sort of stand at about 96% at 12 weeks. So again, we can improve these patients just by introducing simple techniques. Thank you for listening. I'll send you back to Ed, and if there are any questions, I'll take them after Ed's spoken.
Julie, there are loads and loads and loads and loads of questions. So ladies and gentlemen, thank you so much for your engagement and the questions. I'm going to crack on. Before I do, this answers 3 or 4 of the questions. Mobiderm pads and bandages are available on prescription, and our partners 2N have said they're happy to send out free samples if you're interested. So hopefully there's a slide now that will provide the info@2n.co.uk address. Email that, we can get some samples through. And the other thing is, please complete the Mobiderm Products in Practice e-learning module on the JCN site. This also counts towards your revalidation. We'll make sure you use the products appropriately. Julie, thank you so much. I think it was a really important session. If it's okay with you, do you mind if I crack on with the questions? Because we've got quite a few, I think. So question 1 from Sylvia. Thank you, Sylvia. Which technique is better to use in cases where ulcers are present?
You can use all the different techniques. That's the beauty of it. Depending on how the fibrosis is and how it is, whether it's sort of all around the leg or all around the wound area, you can use a combination of the techniques. And sometimes we throw everything at the patient. So it's Kinesio, mobilizing foam pads, strapping, and the lymphatic bandaging techniques. But sometimes just simple changing your bandage technique can actually help, along with mobilizing. If you're worried about sort of doing all the other techniques and not having any training, sometimes just the pads can actually help underneath the bandaging techniques. But I would always say try and change it to a figure of 8 rather than a spiral if you're using short stretch bandaging, because that really does help with lymphedema.
Brilliant, thank you. So question 2, do you need specific training to use mobilizing pads?
No, I mean, one of the things that I would always suggest is you talk to the companies. The companies are more than willing to sort of show you how to use it. And if you contact them, any of the companies will show you how to use their products from a lymphedema perspective. Because again, lots of tissue viability nurses or district nurses are not used to these techniques. Whereas if you actually learn them, they're very, very simple, very, very effective, and you don't need extensive training to actually use them. Brilliant,
thank you. Question 3, at what point do you change the pads for a fresh piece?
Literally, you'll actually see it when you actually feel the actual pads. They've got what we call little nodules in them, little foam padding in them. Once they sort of become quite soft, then you need to change them. I tend to use them for about a week to 10 days on patients. If they're soiled, then we'll change them straight away. But about a week to 10 days we tend to use them for, depending on how much compression has been put on them.
Brilliant, thank you. We're going to pile through these, Julie, I think is the way we're going to do this. Question 4. From Praise, beautiful name, thank you, Praise. How often is the mobilizing foam changed? For example, if a patient has exudate?
If the patient has a lot of exudate, if there's an infection there, I wouldn't use the pads because there isn't any point. You need to treat the infection first. If there's a lot of exudate, you need to change it as soon as it gets soiled, because again, it's just like any other pad that you put on, it needs to be changed as soon as it's soiled.
Brilliant, thank you. So next question from Natalie. What can you do with someone who has excess exudate?
I'd find out the cause of the exudate first. So is it that the edema is not controlled, or have they got an inflammatory or an infection there? Once you've actually resolved that, you need to sort of find out exactly what's causing it first. And it's usually either inflammation or infection, or you've not got enough compression on that patient. That's why you've actually got too much fluid.
Brilliant, thank you. Our next question from Jenny. Does the mobilizing foam actually work if it's on the top of a super absorber?
Yes, it does, because what you're doing is if you've got effective compression, that's what I'm saying about you've got to have targeted compression. Your compression has to be good. Once you put the padding on and you've got your normal sort of primary dressing underneath, and you've got a secondary dressing on the top, you put the mobilizing foam on, and the bandage basically pushes it into the wound bed, and it will actually just move it. So it doesn't have to be in contact with the skin to actually work, because it's that massaging motion that you're actually looking for. So yes, you can put a super absorber on the top. That isn't a problem.
Brilliant, thank you, Jen. Thank you, Jenny, for the question. And Gemma, for the next one. Are the foam pads considered a dressing or a medical device? Would it need to go via a wound formulary for approval?
No, I mean, they're basically used in lymphedema all the time. So they're basically either a bandaging technique or a foam pad. And all they do is they just use to break down fibrotic tissue. So it doesn't have any it doesn't have any effect on the way, it just actually massages. So I wouldn't actually think that it would need to go onto a formulary as such, because it doesn't actually do anything physical to the, that's not the right word, but it doesn't have any interaction with the wound bed at all. When you're not putting it onto the wound bed, you're putting it on the top of a primary dressing or secondary dressing that's there.
And it's available through prescription now.
It's available on prescription, so you know it's something that you would use with those patients that have that fibrotic tissue present. You wouldn't use it on all your patients with wounds. You just use it on those where you've actually got a definite sort of stage 2B, 3 lymphedema.
Fine, brilliant, thank you. Next question: does the pad just go over the wound, or do you put it over the whole leg?
It all depends on, we tend to just use it where the area of fibrosis is. So if you've got a wound bed and you've got quite an extensive area of fibrosis, you use the pad to the size, because it comes in a great big roll. So you just cut it to the size that you need. So wherever you've got the fibrosis, you basically put it there. If it's lymphedema, we do actually use the bandages. But for wounds, we've just basically cut a shape where the fibrosis, if the fibrosis is 5 centimeters around the sort of peri-wound area, we'll cut a size of the pad to actually fit the area.
Fantastic. So next question from Alex: if the patient takes steroids, can kinesio tape be suitable?
It depends on the skin itself. If the skin's very fragile, then no. If the patient hasn't got fragile skin, then yes, it can be used. Because if you can't use an adhesive dressing on the patient, you can't use kinesio tape on the patient.
Okay, brilliant, thank you. So Lucy, next question: is chevron bandaging the same as figure of 8?
No, the chevron band, the actual the strapping is literally where you've got the retromalleolar fossa, and what you have is the bandages don't tend to sort of stay in the area when the patient starts to move. So the strapping techniques go underneath the foot and around the ankle, usually on both the lateral and the medial malleolus. And that chevron strapping technique basically keeps the bandage right sort of sitting next to the retromalleolar fossa. So but the ulcers in those areas, it basically keeps the bandages in place and provides localized compression. Otherwise, if you just do your normal bandaging technique and the patient's got a retromalleolar ulcer, once the patient starts to walk, there is no real compression there. It reduces dramatically when the patient's actually walking and upright. So you've got the star strapping, which is where you put 2 pieces of short stretch bandage over the area, or you've got the chevron strapping, which goes from underneath the foot around the malleolar fossas.
Brilliant, Julie, thank you. So next question from, one second, let me just scroll up, because they're coming through at about 100 miles an hour. From Lisa: what is the best treatment for patients that also have psoriasis?
Again, psoriasis is very different. I mean, you need to really look at talking to the dermatologist about psoriasis, because it's very, very different, and every patient is quite different. So again, it's not something that I would look at sort of treating with these techniques until the dermatologist sort of said what treatment the patient needs, really.
And there's some fantastic education, actually, if you go
Yeah,
the British Association of Dermatology, the nursing
yeah,
group as well, the BDNG. There's loads of
yeah.
stuff on the BDNG website with regards to psoriasis, which you can access there. So next question from Lucy Gray. 10 days, is that the full bandaging? Protocol is 7 days max, especially if there are concerns regarding infection.
No, the 10 days is literally, you're changing the actual bandaging in between. You can reuse the pad as long as the pad's not soiled. So if you're dressing the patient twice a week or 3 times a week, I would use the pad for about 10 days. So every time I rebandaged, I'd use the pad if it was not soiled and if it wasn't sort of squashed, as we call it. So yeah, the 10 days is not you leave the bandaging on for 10 days. You basically just change each time you change the dressing, as long as it's not soiled, you can use the pad again.
Brilliant. Thank you for clarifying that. Next question from Kirsty. Thank you, Kirsty. Am I right in assuming that 4-layer in connection to lymphedema still requires Doppler assessment prior to creating a plan of care involving compression therapy?
Yeah, I mean, any patient that's having compression really needs to have their arterial status checked with a Doppler. Lots of lymphedema nurses don't tend to Doppler. I do. It's something that from a tissue viability perspective, I've always done. But yeah, we Doppler every patient that goes into compression. It's
incredible how many examples I see of formularies and areas around the NHS. I was about to say CCGs, but I'm not sure they exist anymore as of tomorrow, I think, that don't have vascular assessment on the formulary. I mean, I mean, is that your experience? Do you think vascular assessment should be used across?
Yeah, I mean, there are circumstances whereby if you assess a patient and they've got a skin tear and there are no real signs of any arterial disease, the VLU best practice statement says you can put mild compression on for the first 2 weeks. But most patients really do need to have an arterial assessment done. They do need a vascular assessment, and they're really simple to do now. There isn't any sort of difficulty with doing them, but yeah, they should, especially if you're putting in lots of complex sort of targeted compression. You do need to make sure the patient can take it.
Brilliant, thank you. So next question from another Lisa. Would these be suitable for other types of slow healing wounds on the foot, such as diabetic wounds with secondary lymphedema?
Yeah, there isn't any. It's like if they've got fibrosis edema present, then they do work. These techniques will work. And as I say, from a lymphatic perspective, I've been using them in lymphedema for a long time, and that sort of jump from using it in lymphedema to tissue viability was well, if it works for this and it breaks down that hard fibrotic tissue, it can work with it might be able to work in wounds. And that's how we've sort of transitioned from using it from pure lymphedema patients to tissue viability patients, because they've got lymphedema present, and it's worked particularly well. So using all those different techniques works, and I think that's why our healing rates are extremely good. You know, there isn't any sort of secret sauce. We just use what we've learned from a lymphatic perspective and put it into tissue viability.
Thank you. And thank you again to everyone for the questions. They're flying through. Julie, don't worry, there's about 7 or 8 minutes left, and then you can put us a glass of wine. But no, you've also just come back from a flight as well, so I think you probably need a glass of wine. So question 15 from Debbie. Would you take figure of 8 from the foot up or from ankle up?
If they've got edema of the foot, you need to take it from the foot. So you need to start at the base of the toes. If the toes are involved, you do need to either do toe bandaging, and if you can't do toe bandaging, look at toe caps, which are again available on prescription. They're the toe hosiery that we tend to use. But yeah, if they've got edema of the foot, you need to start the 8 from the actual foot itself, the figure of 8. And then we go to the ankle, and then we use a 10 centimetre from the ankle to the knee.
Brilliant.
Again, in a figure of 8.
Okay, so next one, George. Thank you, George. Is fibrosis common to pregnant women?
Not that I know of. It tends to be those patients that have lymphedema that's been long-standing. So if they've had, in my experience, it tends to be those patients that have had ulcers for quite a while that have that recurrent episodes of infection, reinfection. So it's that cycle that they tend to go through. So the more episodes of infection that they have, the wound breaks down again, the more lymphatic disease they actually get. And in my experience, that's what we tend to see. It's in those patients. So the nurses will know exactly who those patients are. As every 8 weeks or so, there's another infection that they treat with either topical or systemic antibiotics or antimicrobial treatment.
Brilliant, thank you. So question 17, Julie, I think that we could be breaking records tonight regarding those questions. So question 17 from Jackie. Is leg elevation still vital for assistance of healing?
It is, but what you have to remember is if the edema is predominantly lymphatic, it doesn't reduce on elevation. So the patient is encouraged more to do exercises. Yes, they should be going to bed. Yes, they should be putting their legs up. But by just saying, put your legs up throughout the day doesn't really help. If they've got lymphatic disease, they have to exercise, because the only thing that moves the lymphatic system along is exercising. So they need to be taught different types of leg exercises. Elevation does help, but we need to look at exercises as well for those patients.
Okay.
And again, there's lots of information out there for leg exercises in patients with lymphedema.
Brilliant, thank you. So now we're on to our last question, which I know will be a relief to you, I'm sure. From Elaine, thank you so much, Elaine. Can the pad be used on a packed wound?
On a
packed wound? A
packed wound. Yeah, it can. There isn't any problems with that. I mean, we've not used them in pressure ulcers. We've mainly used them in leg ulcers. But again, there are things that we are looking at, things like the use of the pads and also kinesio tape with pressure ulcers, where you've actually got that fibrotic wound edges and that hard sort of indurated edema that we're seeing. So we are trying to sort of use it in different ways. But yeah, there isn't really any reason why you can't use it if you've got that type of tissue around the wound itself.
Julie, thank you. Massive thank you. And thank you to everyone watching tonight for your comments and loads of questions. And for the ones we haven't managed to answer, I know we'll come back to you and answer them privately via Facebook. As I said before, if you want free samples, Thuasne very kindly put a link, which is the info@thuasne.co.uk. So please use that if you want samples. And again, please go to the JCN website to download your slides and also to do the product in practice on Mobilizing for your revalidation. The link for your certificate of attendance will be available hopefully now. So download that. And again, just a massive thank you from me for giving up your time tonight. I'm well aware how precious that time is, so it means a lot to me and to Julie. So that ends tonight's event. A massive thank you to Julie, not just for your time now, but all the preparation you put into the event. Thank you so much. To the amazing team at the JCN and Mole for your continued hard work. To our partners at Thuasne, just a huge thank you from me, Julie, and the team. Yeah. Last but not least, to our audience. You guys continue to inspire. Thank you for your trust in us. Thank you for your support. Stay safe, stay strong, and we look forward to seeing you at our next event on July the 13th. Have a lovely evening. Take care. Bye-bye.
Bye.